There we are. I'll turn it over to John Bertoni, our Riverfront Place resident and a doctor of many credentials in his own right. You've done such a fabulous job of procuring a great speaker for us this evening. So John Bertoni, I'll turn it over to you.
Thank you very much, Timothy, and hello, everyone. We're very fortunate tonight for a very timely discussion of how do we stay safe until the vaccines are available. So we need to know this now before the Thanksgiving and the Christmas holidays and other holidays that are coming up soon, so that we can benefit from what our science has brought to the fore. So let me introduce Dr. David Brett Major, MD, and he has an MPH degree, Master of Public Health, just what we need. I'll be quick about trying to summarize his credentials, and he's going to open up with a statement, and he may be able to share his screen with the rest of us so that we can see exactly what we're up against and what he's talking about. So his education, he's actually from the state of Florida, and his education has been at the U.S. Naval Academy initially, and then he was in the Uniformed Services University and did his residency in internal medicine in the National Naval Medical Center Infectious Disease Fellowship at the National Capital Consortium, and he got his Master of Public Health in the Uniformed Services University as well. He's been serving our country for many, many years. He's been a medical officer in the World Health Organization. He's been all over the world in doing his work for the Navy as well as for public health. He was the Sanford Chair in Tropical Medicine at the Uniformed Services University, and now is a professor in our Department of Epidemiology here at University of Nebraska Medical Center. He is very well acquainted with outbreaks and how to focus on the risk, how we identify risks, and how we manage our risks. And he's the ideal person to be talking. I want to thank him profusely because I know how busy the entire team is these days fighting in the trenches in the hospital. And he's worked with Ebola virus. And if you ever get Ebola virus, this is the place to come to. So without too much further ado, I will introduce David Brett Major, who is our guest speaker tonight. This is something that we can't thank you enough for, Dr. Major, and you can take it from here, and you're on.
Thank you very much, John. Good evening, everybody. I was very happy to receive this invitation from Professor Bertoni. I think mindfulness everywhere is relevant for mitigating our risks with COVID-19 and SARS-CoV-2. And so I really look forward mostly to your questions. But I thought, and the professor had asked that I start by giving a little bit of an overview before we go to the questions. And the other thing that I have to warn you about is I have a 1-year-old Siberian Husky who's 60 pounds and teething and currently in the backyard. So if you see me turn my head, it is only me making sure that he's not gone and grabbed one of the neighbors and dragged him to my back door. So if you see me move quickly, it's my dog. So good evening. I'm going to try and share my screen here. It's not letting me do it at the moment, but I do want to set the stage a touch. Only a couple of weeks ago, if you were to look at a map at a website like covidactnow.org, covidactnow.org, and you were to go to that website and look at the map, you would see a diagonal swath of red for high risk for COVID-19 going through the country. If you were to look at that map this evening, as I have done, you will see that almost all of the country right now is red with risk from COVID-19. And so it really does not matter right now whether you are coming from Nebraska and going to California, or whatever the holiday movement that anyone is considering is. The whole US is experiencing the pandemic in a substantive way. Risk maps like this can be confusing. COVIDactnow.org is a nice website. I tend to go there, but you could go to several tracking sites that talk about the data of the emergency in this outbreak and in others across the United States, some at universities and some at federal agencies. And they often give several indicators. The two indicators that I look at mostly are the actual normalized case rates over the previous week, either in the per 100,000 or per million number. And I also look at the test positive rate. So why am I torturing you with these epidemiologist tricks? I think it's useful to have a frame of reference when we look at these things and we look at these numbers. If you go to covidactnow.org and you look at Nebraska and you look at the state where last year I lived, I moved over the winter of this past year, they're both red. But the case rates in Nebraska are 5 times higher. And the percent positive test rate is more than twice as high. And we're frankly months behind systematically applying societal measures here that help to mitigate growth and spread and use of resources. And so that's something to think about.
Dr. Brett Major?
Yeah.
You should be able to share your screen now if you'd like to.
Oh, okay. I will give it a try. Thank you very much.
Yep, sorry to interrupt.
No, not at all. And so here I'm showing you the Nebraska Health and Human Services website. It's a nice website and it gives a lot of information. And you can see here that hospitalizations are as high as they have been. And you can see down here in the left lower corner where I'm moving my mouse that the percent positive rate is high. So let's come back to that in just a moment. I'm going to bring you to covidactnow.org. I will move our pictures over to the side here. I think it'll let me minimize it a little bit. And here on this website, you can click on a state. And so I'm going to go ahead and click on Maryland because it's always fun to pick on somebody who's not us. And you can see that they have 38 cases per 100,000 and their positive test rate is about 9%. They have an aggressive mask mandate. They have other aggressive societal measures, and they are in the red, as it were. They're considered at high risk. Here's Nebraska. We have 3 times that case rate and more than twice the positive test rate. We also have some other numbers here, and it's worthwhile, I think, to talk about why I look at this one, daily new cases, and this one, positive test rate, and I look less at these others. So with the daily new cases, this is a 7-day average of cases. This gives you a pretty good sense of background risk. All of the things that we do to be mindful and decrease our risk are really to bring us back to our background risk. And our background risk is best reflected by something that all of us know who have ever had anybody report to us for any kind of job ever, which is the best predictor of future performance is often past performance. And that's what that number is. That's looking back on an average of the previous week and telling you kind of where you are in your case rates. To put these numbers in context, in the spring, when we were identifying the thresholds for being mindful and aware of the emergency, and when we would have to increase what we are doing, things like shutting down schools, things like shutting down bars and restaurants, we were talking about numbers that were 1/20th the size of the case rates that we have now. Now, this can be a little bit hard to reconcile sometimes, because if we are fortunate to have resources and be living in a pattern where we've been lucky to not interact with individuals who are either directly suffering COVID-19 or had family members to do it, things can look very normal. Because if 105 individuals out of 100,000 did not have, had COVID-19 in the last week, well, that means that well over 99,000 individuals did not have that disease. And so why do we get hung up by these numbers? Part of the reason we get hung up by these numbers is these are essentially the attack rates. These are the new cases. So every week, this is another group of people. Another reason that we get hung up about this is because with COVID-19, if you have one case, in about 5 to 10 days, you're going to have something like 3 more cases. And so these numbers continue to grow. Another reason to be mindful about this is that we only see where we look. And so the actual experience with COVID-19 is greater. Now that gets to the second thing that I look at, and that's this number over here, and that's positive test rate. And the reason that I look at positive test rate is not because I think that 1 out of 5 people in Omaha have COVID-19. It's because it is a measure of how hard we're looking. If we are looking and testing people, and 1 out of 20 or 1 out of 10 or 1 out of 5 of those individuals are positive on that test, what that means is that we're only looking where we happen to notice that there are a lot of cases directly associated to what we're seeing. What that means is that we're not looking around and being very vigilant to try and really understand how many cases there are. So in emergencies, when you're trying to be vigilant to actually actively case find, you really want the positive test rate to be very, very low. That does not mean that there's not significant disease that the community cares about. Our ICUs are bogged with COVID-19. We have repurposed care that other people seek to get instead to be able to deliver it to COVID-19. So it matters right now. But it means that we're not looking enough. So what's a good positive test rate? A good positive test rate is down around 1%. Now, in fairness to us and everybody else, very few communities have been that effective at getting their positive test rate down that low. But certainly, I just showed you Maryland has a positive test rate well below 10%, and they also have about 1/3 of the cases. And so these things can have a cascading impact. So what do? I look at the daily new cases on the 7-day average, whether it's per 100,000 or per million. And then the positive test rate gives me the error bar. So what this tells me is not only do we have one of the highest case burdens in the country right now, we also have a lot of error around it. We don't know how bad it is. And so our vigilance is low. So for us, what does that mean? How do we take this kind of information and put it into a context that we can use when we're making decisions every day? Well, one way to do it is to recognize that what's communicated right now as case rates is probably lower than what is actually there. And any preconceived notions that we have about pockets of our community that have disease is probably incomplete, and it's probably in more places than we think. Now, we've learned this lesson over a long time. Diseases like influenza have taught us that when a respiratory virus that moves as easily as these do is in the community, it's usually everywhere in the community. So how do we deal with this? Well, the obvious things you know. I had a conversation with a major sports league not too long ago, and we were talking about strategies to let them do what they wanted to do. And they were being very thoughtful, a very bright group, and they had a lot of ideas. And at one point I said, well, you know, it is great that you want to do all of this testing. I'm a fan of greater vigilance in testing like we just talked about. But just because you're doing more testing, it does not mean that you do not need masks, physical and social distancing, personal and environmental hygiene, and mindfulness of when you're sick or others are in aggregate settings. And the league people looked at me and they said, well, yeah. We know the usual stuff. And I said, well, if you really knew the usual stuff, you wouldn't be having to test so much because your case rates wouldn't be what they are. Now, they actually did a fantastic job in their setting, but just because we're used to hearing these things does not mean that they're not still the basics. So I'm guessing that there are a lot of questions about vaccine. I'm guessing that there are a lot of practical questions about what to do when coming together for events like Thanksgiving. And so I'm happy to address those, but I'm conscious that I've just been talking for several minutes. I've used a lot of language. And so what I'd like to do is stop for a moment, see what questions there are, and see where you want me to go next.
Hi, Doctor. This is Liz Mazzata. I had posted a question out in the chat about the positive test rates for Douglas County being over 30%. Do we see a higher rate of positivity due to the population density versus the average for the state of Nebraska?
So again, your case burden is your case rate. Your test positivity rate is how likely that case rate is to be accurate. So if your test positivity rate is high, it's because you're looking right where you found a bunch of cases. Your case rates can be quite large, and your test positivity rate can be low if you're being vigilant. If your test positivity rate is high, like what we just saw in covidactnow.org of about 1 in 5 are positive, you're describing 1 in 3 positive. What that means is we have no idea what our case rates actually are because we're only looking where we happen to find a few cases. We have to do much, much more testing. The test positive rate should be down into the 1 in 100 level to really know what's going on broadly in the community. Now, if you were to ask me, why is it that we have some of the highest case rates in the country, even when we're not looking as hard as potentially we could with testing, I will tell you that we're not all that aggregated, right? Douglas County might be high in contrast to some other counties in Nebraska because it's closer to resources that have to do with testing. I had a conversation in a couple of settings over the last week with individuals who were asking me about rural disease because the Dakotas are getting clobbered right now, right?
Mm-hmm.
And the conversation was, well, why is it that rural communities are experiencing this? This is a respiratory disease. Isn't this a thing where people come together in settings like condominium towers and share elevators and right? And these kinds of things. And the answer is, well, it is that, but it's also something in small communities too. I come from a very small town in a Florida swamp, and we all knew each other immediately in that town, right? And in order to do your activities of daily life, you interacted with everybody. And so in that kind of setting, it can move quickly too. But I think what you're talking about in Douglas County to a certain extent is an observation phenomenon. We just happen to be looking more here, but not enough to get the test positivity rate down.
Thank you.
So what is the difference between Nebraska and Iowa in terms of the urban versus a rural positivity rates, or is there a difference?
I do not know enough about Iowa numbers to let you know. All I can tell you is that we're all sitting here in a big swath of really high case rates, and that it hasn't mattered recently whether it was urban or rural. In the spring, our case rates tended to be either urban or in areas that were, if they were rural, associated with either long-term care facilities or critical infrastructure employees who still had to aggregate for work in a situation where many of us were not coming together. Now that has been flattened a lot, people are pretty much getting it everywhere.
Doctor, there was a question in our chat about, do you recommend routine testing, perhaps weekly or at some regular frequency for the general population?
I think that testing should be based upon the use case that we want to identify for decision making. And so, you know, I am not sure that we would be able to test everybody every week in the United States. I'm not sure that we have the reagents and the test numbers available for that. However, if you have situations where folks are coming together, or you know that a particular community is impacted more, then there's a role for more frequent testing. And so that is not a bad thing to do in a setting where you have people coming together in ways that cannot strictly adhere to the basic things that we all should be doing. So how is that for a non-answer? The answer really is maybe. It depends why you're asking the question. We are right now, thanks to the Sherwood Foundation, with a grant to Omaha Public Schools, piloting a frequent screening program with Omaha Public Schools. There are a few schools that were identified by Omaha Public Schools, and these are schools that are in session during this period, and they are being assessed with consent-based, so it's you opt in testing for students at Omaha Public Schools. So I'm not leading that. My colleague Professor Broadhurst is doing a really extraordinary job doing that. And that is assessing regular testing in a population that is being brought together in ways that other people in the public are being told not to, right? We're putting people in a room together. They're being very careful about it. You know, they're spacing people out 6 feet in the room, but they're still in the room for hours together, and they're still interacting with others in various ways, even though they're trying to be mindful about it. And so in that setting, regular testing makes sense. So it just depends what you're going to do with the information.
I mean, I think kind of surrounding all this conversation, there's a sense, there's a question out there that there's a sense that the small towns surrounding the metro area are going to be safer because they're smaller. And I guess maybe if you could just answer that sort of simplistic question, that would be helpful.
Yeah, no, they're not safer. This is what we were just talking about a moment ago. You know, if you had asked me that question in the spring, when we were pretty much only seeing cases in the major metro areas and in areas of long-term care facilities and critical infrastructure, and these things were much more focused, I would say, well, maybe it depends on the community. The whole country shows red and risk right now. And so I think what we're seeing in the Dakotas, what we're seeing in Nebraska, and sort of the gentleman who asked the question about Iowa, it may be the case there too. I'm just not as acquainted with that state's numbers, is that, you know, it may happen differently. It might not be in a city where somebody who's an asymptomatic shedder is sitting next to a heater vent in a bar or a restaurant and it becomes a super spreading event and the whole room now goes down with COVID. That's an urban, very urban kind of scenario, right? In the small town scenario, at least where I grew up, you didn't accomplish anything without interacting with your neighbors and coming together in ways. That's a different kind of thing, right? Where your whole community is a tighter circle, and so it moves very quickly. So no, I think you cannot make that presumption.
Doctor, I read the article in the Atlantic this week that focused on UNMC as kind of the model in the country. And it was frankly frightening. I mean, the quote in the headline is, "We are on an absolutely catastrophic path." Can you comment on where we're at with the hospitals right now? And after reading that article, I'm not understanding why we don't have a mask mandate throughout the state.
Well, you're not alone. A lot of municipalities have decided that mask mandates make sense. Here in Nebraska, it is not enough alone. It is not a magic bullet. In order to really succeed in societal measures individually acted, right? You have to do these things together. You need masks, physical and social distancing, personal and environmental hygiene, including hand washing, mindfulness when you're sick or others are sick, and of aggregate settings, right? Not putting yourself in situations where the likelihood of running across somebody who may be either unaware or unwilling to self-identify as ill or asymptomatic can influence a group, right? So all of these things matter together. Even when you introduce a vaccine, that's the case, and we can move on to that as well if you all want to. So I think I think it does make sense to think about these things as layered, right? You need multiple reasons to be doing things that don't make sense. Is one way to think about it. What do I do when my children are near a knife? Well, I don't want them to run with it. I want to make sure they know how to cut vegetables with it and keep their fingers out of the way. And I never want them to pick it up in anger, right? So it's not one thing that you communicate in anything that we do safely, right? How do you drive safely? Well, you have your seatbelt fastened, your lights are on, you're at least acknowledging the advisory nature of traffic laws, depending on which county you're in. These are the things that you do. As to the status of Nebraska medicine, it is under stress. There are plenty of procedures and things that were non-emergent that are not able to happen. And as some of you may know, just because you don't need something tomorrow does not mean that you haven't been waiting for it and needing it before too long. And COVID-19 has replaced a lot of that activity. And eventually the time will come where somebody's going to need a ventilator and it's not going to be available. And even if the box is available, the person to be able to monitor it and take care of somebody when that's the case is not going to be available. There are a lot of critical access hospitals in Nebraska and inter-tier hospitals, so in between the small health centers but before you hit something like Nebraska medicine, and that are full. So this whole definition of full gets very wacky too. You only have so many people who can do so many things, and as you keep turning off other services and occupying more and more of your capability for COVID, that you just don't have a lot of resilience. That's not unique to Nebraska, by the way. That right now is a national problem. So there's no magic pool of staff, for instance, that we can draw on to try and get out of this.
There was a question specifically about the effectiveness of wearing masks, but I think you pretty much answered that there without it having to be asked. So thank you for that.
Yeah, I think maybe the one thing I will add to what I've said on masks is that, I mean, for decades, we've used masks with patients who have respiratory symptoms, who have a cough or something like that, to avoid spreading out. But we've actually been I was a little bit surprised actually by some of the data that's been coming out over the last few months that actually suggests that droplet masks are a little bit better at dropping risk, casual contact risk from droplets and spread that can happen, that is inadvertent, that you can't avoid. So masks are a pretty useful thing, and they're probably a little bit more useful than I was giving them credit for, in terms of, I knew I was wearing a mask to protect you. What I've started to realize is that to a certain extent, I can use it to protect me as well. For healthcare workers who are much closer to individuals with symptoms, it's a little bit of a different story.
So, you commented that one person who's infected infects three. I think as an epidemiologist, I know a number of studies have shown that the super spreader phenomena occurs where significant number of people who are infected don't infect anyone. About 10% of people who are, if you will, the super spreader. And the key to managing that is contact tracing. And what's interesting to me is that contact tracing has not been something that's been on the forefront, either in the public health sector or even the University of Medical Center have discussed about the need for contact tracing.
Well, we don't own the contact tracing process at the university. And I agree with you that the conversation about contact tracing has been slow everywhere. And I'm not sure why that has been the case in the US. To a large extent, this is a US weirdness. If you look at South Korea's success and what they've done in Japan and in Singapore and other places, and some places in Europe, it's been very contact tracing based. The conversation about contact tracing has been weird for me too, also because people are talking about a lot of innovative contact tracing that in my day, and perhaps yours, when I was first learning about contact tracing, was usual. This idea about looking backwards several days from the point that somebody was febrile, that's just how you do contact tracing. But because so few people were talking about doing contact tracing vigilantly in the spring, that if you suddenly said something like, when somebody has a fever, I'm going to concentrate on who they saw in the last week more than I concentrate on the people they may have seen in the last day. And they got a lot of press. They published papers on this, but I thought it was kind of interesting. And it just speaks to this funny thing where we're not talking about it very much. I'm not sure why. I would be guessing why it hasn't been more aggressive everywhere. I will tell you that contact tracing hiring has been up of late, in that there is a lot more local interest in contact tracing. And I know this has been true in Douglas County, and I know it's certainly been true with the pilot program that we're doing with Omaha Public Schools. So I really appreciate your comment. Contact tracing matters. This business about super spreaders, yes and no. So people who are in aggregate places often do transmit. But you're right that super spreading events certainly are problematic. And the way, of course, to impact a super spreading event, to prevent it, is to prevent an opportunity for it to be a super spreading event, because you don't have that many people close together. And so in addition to the contact tracing issue is the basic interrupting the opportunity for transmission aspect, which is masks, physical and social distancing, personal and environmental hygiene, mindfulness when you're sick and others are sick, and of aggregate settings.
Dr. Brett Major, I've got a question, and I would like to ask sort of like an aggregate question. If you were the newly elected president of the United States, and you wanted to lead the country and let everybody know what are the important do's and don'ts, would you include things like taking a daily temperature? What would you say about airplane travel these days over the holidays? What are the risks? And if we are going to get together with family over the holidays, how large a group, how can that be done? I mean, outdoors is much better with social distancing, but what are the practical things that we can all do? And finally, if this isn't a complicated enough question, when the vaccines do come and are available, when will everybody be able to get a vaccine?
Well, thank you for the softball question. You have, you clearly, I've gotten some decent questions from folks in the room here. So maybe there's somebody here who's better at answering these than me. I am not, I have not sought, nor would I accept that office currently. However, for me, the true intervention is a focused national effort on mask use, physical and social distancing, personal and environmental hygiene, and mindfulness of when you're sick or others are in aggregate settings. And part of that would include, before engaging in interactions with others, self-screening and self-assessment.
Yes.
And whether or not that has to be a thermometer, I do not know. And its impact will be variable. So it is possible that you might get some individuals to, and I apologize for butchering your name, Mr. Hugh, but to his question regarding the super spreading events, or his observation rather, you might get some in that way. Certainly in middle-aged to older adults, it's a little bit more common for us to associate symptomatology with transmission than not, but you can still be an asymptomatic transmitter and be a middle-aged or older adult. And the reverse is true with younger folks who may be more likely to be completely asymptomatic and transmit, yet might be sick. So it's a tool, it's an easy tool. If you feel sick, why complicate things? Mm-hmm. And so I think that would be something to do. The other thing that it would help, of course, is it would help with influenza mitigation. And so we're running into this period where the risk of COVID-19 and the risk of influenza conjoined is high. And the consequences of having both might be quite severe, but the system strain, both at home and work, and also in the health system, of having influenza, and then somebody has to worry about whether it might be COVID, is quite problematic as well. And so we really do not want this to be a big influenza year also, because that will burn many of the same resources just as quickly as if they turned out to be COVID patients, because of the way that we need to do isolation and quarantine. And so that's something to think about. It's also true that we should never minimize influenza. The number one priority for the National Institute of Allergy and Infectious Diseases last fall, for which they were going to prioritize all research funding, not move all funding to that, but put it in its first tier, was a universal flu vaccine. So we just should not forget how devastating actually seasonal influenza is every single year, with hundreds of thousands of deaths, and often in the same high-risk age group as COVID-19. So all of that is something to think about. I think I would advocate strongly for the influenza vaccine. And these are the messages I think that we're hearing. I think that most of the national voices that are talking about risk mitigation and COVID-19 are saying these things. And it probably gets exhausting to hear it over and over again. but it can be exhausting to be reminded to fasten your seatbelt, but we still should, right? Some things are just obvious. Now, what to do about that aggregate setting for Thanksgiving? I think that the guideline for smaller gathering, for virtual contact, for thinking about being innovative in how we interact over the holiday is a good thing. I think that certainly people who are at risk of a severe outcome from COVID-19 should really take pause before deciding to come together with others who may have not been able, because of life, school, and work, to adhere to strict physical and social distancing practices and who might be at risk. And I have told family members who have asked me this question, who have my older cousins who are very at risk, that maybe they need to stay at home this year. It's also true that the process of movement now at the heat of the pandemic, and I say that, but every time I thought we were at the heat of the pandemic in March, and it's worse now. But the process of travel carries its own risk. And so even somebody who has been trying to be careful in advance of a family event, well, the moment they do a layover at a major metropolitan airport, that risk has changed. There may be opportunities for some to do the holiday outdoors and to really be able to observe being in the same place, but still observing the usual rules. But Thanksgiving is it is actually my favorite holiday for coming together. And it is, it's hours with people in an indoor space. It's very high risk right now.
So, Dr. Brett Major, maybe to answer John's question is really to identify our failure here in the United States, because when you look at China, a population of 1.3 billion, their last numbers on November 22nd, they've only had 22 deaths. And so they actually started putting out the vaccine, but primarily the issues that you talked about, which is distancing and mask wearing and hygiene, but also surveillance has been a key. But the challenge here between the two cultures is that, there's an abeyance to so individual rights, if you will, for surveillance. And so that in itself, I think, is the contrast between our two countries and other countries like South Korea, for example. So until we adhere to those issues that you talked about, my fear is that this is going to be off the rails for the foreseeable future.
I think that's well observed, that if we're able to communally do the basics and participate also in being vigilant and include contact tracing and get serious about case finding and mitigating opportunities for risk, we're going to be successful. And if we're not, we're going to continue to see people afflicted. And I think that is true. So the question, so John had asked the question about vaccines. There are a few things to say about vaccines. So first of all, great news this fall about vaccines. We may be in a very fortunate place with vaccines. There's several vaccines now with data going to the Food and Drug Administration, and we'll see. It's also actually early. They have a ton of data, but it's still early days in terms of analyzing that data in the way that we do under strict peer review and for regulatory clearance. And so we will know when we know. That's going to take weeks, and it better take weeks, because it has to be deliberate and it has to eventually result in peer review and transparency. And so that's going to have a trajectory. The other bit is you all have, as taxpayers, invested in acquiring a whole bunch of candidate vaccines as though they were going to be licensed. And so we're not as far behind in having some vaccine available when a vaccine gets an emergency use authorization. But we're still talking about something like 1 in 10 of the population that could be covered by the vaccine, and they'll have to be prioritized, and they'll have to be prioritized both by feasibility and individual risk, and why we would want that particular group protected, such as healthcare workers and critical infrastructure and things like that. So we probably would not, even if everything is great, even if that is the case with these candidate vaccines, we will not have broad availability of vaccines until the spring or summer in the best case scenario. And so we still need to do the basics. In fact, even if you're in a group that is going to get a vaccine tomorrow, we still need to do the basics. So the performance of the vaccines that's being talked about, they're talking about it as though it's going to protect 9 out of 10 people from getting disease if they're actually exposed. That's the narrative. At about this point, some other very good vaccines, for instance, for Ebola virus disease, they were performing this way too, if you looked at the data in that way. But by the time you got to actual real world use and you saw how the thing performed, it was more like 7 out of 10, which is still, by the way, very good for an emergency vaccine. It's not a panacea. It's not everything. Even if it's every 9 out of 10 people, that means 1 out of 10 people might still get infected, might still contribute to onward transmission, and might work against you with the vaccine. So even an almost perfect vaccine, widely distributed, still needs everybody to be vigilant, to include the personal measures that we talked about: mask use, social and physical distancing, personal and environmental hygiene, mindfulness of when you're sick or others are in aggregate settings, that, as well as what you all have been talking about, vigilance and surveillance testing, contact tracing, and taking steps to decrease community risk. Did that respond to the vaccine question?
Definitely. Thank you so much.
What else would y'all like to talk about?
The healthcare workers. I can't imagine going to work every day knowing what risk awaits you, and on your way in or on your way home, observing laxness and being cautious and et cetera. I mean, I can't imagine that world and the pressure. Is there anything going on in our community to send any kind of appreciation to the healthcare workers that we could contribute to, or we could start?
It's a very gracious question. I do not have a good answer for you. I know that there were some initiatives around something around Public Health Day, that there were some activities there. They're in. I appreciate your asking the question. I'm not useful for you. If you are moved to think about those issues and of healthcare worker need, you could reach out to Nebraska Medicine, and they probably would have an idea about it. And I'll ask some questions too, and hear if I learn anything about healthcare worker relief for those in extremis, and I'll pass that to Professor Bertoni if I'm aware of something like that. I don't know. I've gotten some pretty sophisticated questions. Perhaps some of you know the answer to that.
Well, I do know, this is John Bertoni, that we owe a debt of gratitude to all the people on the front lines. They are stressed. And when I talked to Dr. Mark Rupp about this presentation, you could tell he feels the awful responsibility. And I'm very glad that this is a wonderful presentation, by the way. Thank you so much. But this is what we do. We put ourselves on the front lines every day, and we know there's a risk. But we do everything that you've been telling us, and everything, the social distances that we have in our own workrooms is not enough. And we have to be vigilant all the time. It's a risky thing, but we're very well trained, and we talk about how to mitigate against depression and burning out. And I see my colleagues, the doctor next to me in the office and the person across the way, both contracted COVID-19. And they're back in business, and they quarantined, and they didn't have a bad case, but you have to be lucky as well. But there are a lot of dedicated people. I just fear if the holidays is going to open up even higher numbers, then we're really in trouble. So this message has to get out to everyone as soon as possible. Thanks.
So I have a couple questions, if I could. So I understand that your community uses, there are 2 apartment towers and also a series of townhouses.
Yes.
So I can envision how individuals in the townhouses might be able to mitigate, have more autonomy and control over mitigating their risk. What's done systematically in the towers regarding?
Well, Timothy can answer this better, and other people on this Zoom meeting can do it. But we have a mandatory mask in public areas that has been pretty well enforced. The enforcement's a problem, but we all, I think, adhere to it as much as we can. We have workout rooms that are common areas, and people social distance and may not actually work out, wait till the area is empty. We have a limitation here. I'll let Timothy go into this because actually we have done a very good job. We have a committee with John Brandstetter and Timothy Schoenfeld and others, Dan Hemmings, that have really been very vigilant, and we have deep cleaning of common areas frequently. I'll let Timothy take it from here.
Yeah, we've got concierge staff. In addition to what Dr. Bertoni just mentioned, our concierge staff have hourly cleaning routines. So they're cleaning the high touch areas, the elevators and door handles and mailboxes, countertops. We've got social distancing. We've got some markings on the floor to keep people further away from the desk as they pass through the lobby. We've got an additional weekly deep cleaning in addition to the normal cleaning of the building by a professional company. John, tell me if you think I'm missing anything. We're doing temperature checks for any contractors that are coming into the building. And again, the mask mandate for anybody in the common spaces. Encouraging people to ride the elevator, one group at a time, not sharing the elevator, or at least being cognizant that some people may not be comfortable with that. So I think that's pretty big overarching amount of what we're doing.
I think all the meetings now are virtual. I mean, we don't have any gatherings in our common areas like in the Riverfront room or the Skyline room.
Yeah, that's true. Our board meetings are virtual, and a lot of the committee type meetings have become virtual, and we've got limitations in our community rooms. We have 2 community rooms. Each of those are reduced down to 25% of the fire captain's occupancy rate, which is about 12 to 13 people in either of the 2 rooms.
I would say that we have put process and procedure as far as deep cleaning and as far as hourly cleaning in both towers. We do have a mask mandate. We follow what happens as far as the Douglas County and Omaha has. And yes, contractors and vendors have to be temped when they come into the buildings. We've taken as much care as we possibly can for anyone entering our community. And to this point, and I would have to say it's the best of our knowledge because we don't really know, no one has contracted COVID, and I would say that we know of. So, but that doesn't mean we have to even be better than we've ever been before, because we started this in March and we've been very diligent to this point.
Yeah, we also, I'll just say this, our staff used to go inside people's condos quite frequently for just little odd jobs and tasks throughout the day, and that has basically disappeared. You know, just that additional opportunity to share and spread we've tried to eliminate that. So we've done quite a bit, and I think John, and of course a lot of people get a lot of credit for that, but John Brandstetter was a big proponent of that. Not that he's looking for accolades, but early on when people were still wondering if this even was a thing, you know, he was right there on top of it. So
Cool.
yeah. There was a question about whether or not, if I may, there was a question about if you foresee rationing of medical care in the near future, or maybe that's already started. I guess maybe you're already, I guess by virtue of the electives are not happening anymore, right? So it's essentially, we've begun that process, right?
If you were waiting for a joint replacement, you're likely to continue to wait.
Yeah.
Yeah. So it's a fair question. And I think your point, Timothy, is right, that, you know, we think a little bit weirdly about what it means to be full. You know, we've already started shifting our practice patterns and our resource availability. That's been going on for some time. And now we're also having conversations about what to do when really all is available is a big tent and an oxygen manifold outside. We're having those kinds of emergency conversations already.
Could I ask this question, you know, because I think it's maybe timely with the vaccine conversation you were having. You know, there's, you know, mixed messages, just depends on where you're looking and where you're listening. But you as a healthcare professional, the vaccines that they're talking about, if they get the approval that they're seeking, should the public be concerned about seeking out or receiving those vaccines? Is it expected that they're safe from the medical side? Is that kind of a non-issue? Or you know, some people puzzle at how quickly they've been able to come up with this stuff, and if there's any other, you know, things to be considered. But if you could speak to that.
I think the main reason that they've been able to move these things forward is that we've all been so colossally bad at doing the basics to control the pandemic. And so they've had enough events, right? They've had enough cases, and enough money was sort of thrown at it to enroll a bunch of people to be ready to get the disease. And they have. And so, you know, the vaccine trial success is another manifestation of our failure to do the basics. And so it's unfortunate, but it does mean that there's a lot of data. What there's not a lot of is long data. Yeah. And so I suspect we'll have to see. It's only just gotten to the agency. It will, my understanding is that it will go through the usual kinds of review. And then if it looks like it's appropriate, and certainly the makers have said that they're comfortable, and that's actually a big deal. People minimize the importance that the big makers are comfortable with their vaccine. The reality is these are very risk-averse organizations. They have a lot to lose if there's a problem with one of these products. So it actually is non-trivial. If a company like Pfizer says that they think it's appropriate, that might not mean it's a silver bullet, but it probably does mean that they do not expect consequences from moving it around. So that's actually a good sign. When it goes through regulatory review, we'll have to see. That's what I meant earlier about appropriate transparency and peer review, and it needs to come through the process. From what has been communicated about these products, they seem to be reasonably, if not even better in efficacy and effectiveness, and well tolerated. And so that is very good news. And hopefully the data bears out. Now, an emergency use authorization is different than licensure in a very important facet. A licensed product is put out on the shelf, and then it might, ever since, if do y'all remember Vioxx, rofecoxib, Vioxx, the COX-2 inhibitor, the drug you would take instead of aspirin for your joint pain so that you wouldn't get an ulcer. And that drug was pulled from the market because people started realizing that when you take the action that aspirin does and you only do part of it, that it turns out your body kind of knew what it was doing, and it didn't want you to do things that way. And there was a mild increase in heart attack. I don't know if you remember that story with Vioxx, but what that did is it created something called phase 4 trial analysis at FDA. And so post-marketing analysis. So now you get onto the market, and there is a routine process of looking just to make sure that no surprises happen and safety signal. This has happened with the vaccine. It happened with not the current rotavirus vaccine, but the previous one. If any of you are parents, you might remember, or maybe if not for other reasons, you might remember that there was a concern, there was a small signal of what we call intussusception. So kids, they'd have the rotavirus vaccine and they'd have diarrhea, and there was a problem with the gut. And so that vaccine got pulled in what we call post-marketing analysis. And that's kind of a long-lived process that is important. It's a change really since Vioxx, since rofecoxib, but it's out there. In emergency use authorizations, that is a bit different. What happens with an EUA is that the agency does not say, this is great, sell it where you can, and we hope people use it when they think they're going to have value. Go out into the world and do good. It's not that. It's not licensure. It is the agency saying, in this particular scenario, the benefits outweigh the risks because we're in an emergency. But we're going to keep looking at this information, and we reserve the right to change our mind at any moment. So I think probably the vaccines are reasonably effective and well tolerated, and we'll have to see how the data goes. When they're released, they'll be under a mechanism where there'll be some very close scrutiny as it continues to be used. And so I think, I'm optimistic. That was a really long response to your question, Timothy.
I have heard that Dr. Fauci's statement is that he believes that it may be these vaccines could be distributed very close to the first of the year if everything goes smoothly. And perhaps by April or May, it might be available to almost anyone if there is an ample supply and if there are enough samples that can be delivered to the right places. So that gives us hope that if we do the right things and all those things that you listed, by the way, there is an app called OneCheck that we are using now that asks the questions that, when you go to a hospital like the Mayo Clinic, they stop you at the door and they make sure that you answer the whole long list of questions. And we do the same at UNMC. And they will take your temperature on your skin, which is, something, but it's not perfect, as you were saying. I think if we do all these things, there's a really good chance we'll come out of this as well as can be expected. We could have done better, but we've got to do the right thing starting now.
We're starting to see case growth rates now where if we want a good outcome, we have to all be in it.
Are there any other questions? Because I know it's the question people were not sure they should ask that sometimes is the most important one.
I have a question, Liz Mazzata. It appears we've got several months ahead of us now as we go into winter, and my curiosity is about battling COVID fatigue. And there are lots of good resources out there to help with that, encouraging exercise, mindfulness, those kind of good things. But just curious, doctor, to see if you have any tips for us as we go into the winter months.
So where I went to college, we used to call the period between January and March the dark ages. and there was no COVID-19. And so we're hitting it. It's well spotted, right? We're hitting a time of year where there is joy and frustration in all of us. There's joy and frustration when you get together with family, and there's joy and frustration when you don't, right? Depending on which family at the moment.
Mhm.
I have no secrets, secret source of wisdom on this one. I think that we have to identify individuals around us of whom we can say things out loud and seek help. And sometimes the answer that we need to receive is, did you know that Channel Z has yoga? And sometimes the answer we need to receive is just do 20 push-ups and have a beer, right? The answer we need at any moment is going to be so dynamic. But I do think that since what most people articulate, at least that I hear, that they're concerned about is isolation, that the one strategy is the one consistent strategy, and it's an issue with the dark ages regardless, is fighting isolation, fighting that it's dark at 5:30. I'm not going to interact with anyone now. I'm just going to go to bed. These kinds of things, and just being aware of our own isolation that's self-inflicted rather than elsewhere. And I do think that we should continue to push each other to be innovative. There's a lot of innovation out there for business. There's a lot of innovation out there for education. There's a lot of innovation out there for recreation that can adhere to the basics that we talk about, right? And we just have to, for me, I have to always, when I'm getting frustrated about whether or not I can do a thing, if I stop and ask, well, what is it I wanted from doing that thing? If I flip to thinking about interests and not a position or a presumption about how something should happen, sometimes I can figure out a way to actually get what I want. And I'm not quoting the song on purpose by saying that.
Thank you.
I think that's a really good question, because we should reach out to others and make sure that they're doing okay. I know Chancellor Gold has done a fabulous job making sure that we're looking for burnout in not only the nurses and the doctors, but also in the patients, the people at the front desk, our friends and neighbors. I think together we can really help each other. And if it is just go to the Channel Z and get yoga or whatever works for you, get a Siberian Husky, who knows? Whatever it takes, let's be available to each other.
Right.
Yeah, if you decide to do the Siberian Husky thing, really, you might want to reach out and talk to me before you do it. He's awesome, but I'm sure he has a couple words to tell me here in a minute or two.
Thank you very much.
Well, are we zeroing in on any final comments, perhaps? It looks like I don't see any new questions coming up in the chat, and I want to be conscious of your time. You've spent over an hour with us, which we are grateful for. Are there any parting words for the group that you'd like to get out?
Oh, I think I've spent enough time on a soapbox with little data already as it is. And so I'll just say thank you very much for having me in the conversation. It was really good to hear your questions, observations, and insights. And I wish you a fantastic holiday season.
You were
Thank
great.
you very much.
You were great. Thank you.
Thank you so much. Yep. And we recorded this session, and we will be, as soon as the video is available and can get can get manipulated here. We'll get it up on YouTube, and I'll share that link with the community. So if anybody's missed it, we can share that around. And once again, a big virtual hand to Dr. Brett Major for taking your time to share with us. And thank you, John Bertoni, for organizing, and John Brandstetter for your efforts as well.
And thank you, Timothy, very much.
Thank you
Happy
all.
Thanksgiving. Yep. Everybody have a good holiday.
Be safe.
Thanks.
Bye now.